Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Today, inshallah, we will continue our session reading Hunter book. Today, we will read case number 7, post-traumatic sensory exotropia. Dr. Sarah, can you please start reading?
Yes. 17-year-old boy present for correction of a wandering left eye, which turns out and up. He suffered a severe head injury 5 years previously, resulting in a loss of consciousness and hospitalization, stay in ICU. In ICU, he was diagnosed with esotropia and left 6 palsy. Initially, he had light perception vision in both eyes. However, the vision in the right eye recovered and subsequently left eye began to drift out. Now a high school senior, he is asking what can be done to restore the normal position of the eye.
Okay, Dr. Muhammad, do you have any comment here?
I think everything is clear. This patient has a trauma resulting in loss of consciousness and hospitalization. Okay, developed left sixth nerve palsy. Okay, and after that, I don't what the cause of poor vision here, but a lot of things. Okay, we will see in the text and examination. So after that, the sixth nerve recovered, but after that, due to poor vision, the eye drift out. Okay, let's see.
Yes. Okay, continue.
On examination, VAOD 20/20, OS light perception, manifest refraction, OD plano, OS plano plus 1.25 in 50 degree. External examination, no head tilt, sensory motor evaluation, right eye fixation preference for distance and near. So in motility, there is a limitation in right eye, elevation, يعني up and in adduction and upward, while there is overaction left eye in opposite direction, يعني inferior nasally.
Yes.
So here right inferior oblique under action -1,
Yes.
and left superior oblique over action +1.
Yes.
Essentially full duction and version, low amplitude, low frequency, wandering eye movement of left eye in all directions were noted. يعني wandering eye بالleft eye.
Wandering eye due to very poor vision.
Yes. Deviation, krimsky estimate, cover test not possible due to poor vision left eye. Near ortho test estimate exotropia 30 to 35 prism diopter. Left hypotropia 8 to 10 prism diopter. On near, I don't know DGH estimate, what did it mean? Exotropia 25 prism diopter. بالprimary position exotropia 35, left hypertropia 4 prism diopter. In right gaze exotropia 35 prism diopter. Right gaze exotropia 30 prism diopter, left hypotropia 6. In up gaze exotropia more 40, in down gaze exotropia become low, يعني this 30 prism diopter. Pupil examination, left afferent pupillary defect. Confrontation visual field, Goldman field performed elsewhere has shown septal nasal constriction of smaller isopter in the right eye.
Okay, perfect. Do you want to make any comment here, Dr. Sarah, on the pictures?
In the primary position, right is in center, and the light Hirschberg in the center, left اكو exotropia. Up gaze, down gaze ما عندنا فد شيء. بالليفت left gaze normal. Left upper gaze there is
Here overaction of superior oblique +1,
yes,
and here under action about -1, as they mentioned.
yes, not so obvious, honestly.
Yes, not so
Right,
obvious.
left gaze normal. بس right upper gaze, right up, I think there is inferior oblique overaction also in the left eye.
You mean here?
Sorry, I
here,
have
here.
some comments.
Yes, Dr. Muhammad.
I have some comments on measuring the angle of the squint. We have two types of measurement here. The first and the accurate methods, it's about the cover and cover test, which targeted on the object. Okay, cover and uncover, or alternate cross cover test with the prism. This is the accurate method, but these methods require three things: enough vision, and enough motility, and bifoveal fixation. If you lost any of these requirement, you cannot do the alternate cross cover test. Okay, so the alternate here, it's about the krimsky. Krimsky, it depends on light and the prism. Just, it's an objective, not a subjective. It's an objective. The krimsky, we have two types of a krimsky test: the krimsky and the modified krimsky. When you are holding the prism in front of the deviating eye, this is the krimsky test. When you are holding the prism in front of the sound eye, this is the modified krimsky. And here we use the modified krimsky. So the method selected here is a modified krimsky because of the very poor vision in the left eye.
Yes, we can see here the reflex, Dr. Muhammad. I see it at the margin of the pupillary reflex.
You
This is
know
in
the
Hirschberg.
Hirschberg test. Yes, this is the Hirschberg test. It's not accurate at all. We cannot depend on Hirschberg test, especially if we go for surgery. So
Yes.
you should measure the angle. As I mentioned before, we have two types of measurement: the light based and the object based. The light based, we mean the krimsky, and we have another test which also called Brackner test. Brackner test. But here, the famous one, this is the krimsky test, either krimsky or modified krimsky. On the another arm, the object-based test, which is alternate cross cover test.
Yes. Thank you. And just to add a point, when we do the alternate cover and cover test, when you make covering, you look always for tropia. This is very important. So when you cover the eye, you look to the other eye. And when you uncover the eye, you look at the same eye that you cover it. And you look when you do the uncover for the foria. And the alternate cover and cover crossing test, you look for both of them. Okay. Dr. Sarah, let us continue.
Yes, dilated fundus exam, OD normal, OS diffuse optic nerve pallor. There is a +1 fundus extortion in both eyes. Dr. Hunter assessment: the patient has a sensory exotropia that is symptomatic, the small but variable vertical misalignment and some discrepancy in the measurements. My plan is to perform an adjustable recess resect procedure on the left eye, operating for 25 prism diopter by krimsky, and with a sufficient additional resection to allow adjustment for up to 35 prism at the orthoptist measurement. Reviewing my surgical table, this corresponds with a medial rectus resection of 4 to 5.5 mm, and lateral rectus recession of 6 to 7.5 mm. Considering that the left hypertropia, which we saw at distance, is more noticeable than a left hypotropia, which we saw at near, I plan to displace the insertions of both recti downward to err on the side of ending up with the left hypertropia. Some surgeons will place just one muscle on adjustable suture in this situation, but I prefer to use adjustable sutures on all muscles because it allows for maximum flexibility when it comes to adjusting post-operatively to balance the alignment in different directions of gaze.
Okay, Dr. Muhammad, what did you think about his plan of?
When we are dealing with the sensor exotropia, most of surgeons prefer to operate the sensor exotropia, the non-fixating eye, because we afraid from a complication of surgery on the sound eye. Really, but in in real life, the result, if you are operating on the sound eye, the effect will be more predictable, and the risk of recurrence will be very low if you are operating on the sound eye. But in the real life, no one operate on the sound eye. Almost the almost of the surgeon operate on the sound eye, and sorry, on the non-fixating eye. So here we have just one type of the surgery, which is resection of the lateral rectus here, and the resection or tucking or plication of the medial rectus. I don't prefer the adjustable suture. I can predict because of the variable angle here between 25 and 35 prism. I can decide to operate on the 30 prism with a 7 millimeter recession of the lateral rectus and a 5 millimeter tucking of the medial rectus. Or if I decide to resect the medial rectus not tucking, like a 4 millimeter.
Okay, another just I want to ask you, Dr. Muhammad, for two things. First, the question about he make downward displacement of the insertion of the muscle. He displaces the insertion of both rectine downward to error on the side of ending with the left hypotropia. So I didn't see in the pictures like actual or real hypotropia, but
Yes, because
he
of that,
downward.
I will not shift the lateral or medial rectus either on upside or downside. Okay, if you have a very frank hypotropia or hypertropia, you can shift the lateral and medial rectus upward and downward. Like if you have a hypertropia, you can shift the lateral and medial rectus downward. If you have a hypotropia, frank hypotropia, you can shift the lateral and medial rectus upward, because if the medial and lateral rectus shifted up, the action of elevation of the eye will increase, so you can correct the hypotropia here.
Okay. Another question. You know, it's an amblyogenic eye. There is light perception, very poor vision. There is sensory exotropia. So here after you just correct the strabismus, there is high risk of recurring exotropia.
Yes,
Uh,
because we have a very poor vision here. The one thing of the that will prevent the recurrence, or to lower the recurrence rate, that you should have a patient with a very good vision. But if you have a patient with very poor vision, the recurrence rate will be very high.
So my question here, you prefer your result to be esotropia because there is recurrence exotropia in these cases. What is your plan of your result to make him
No,
a little ESO or
no,
ortho?
because
Yes.
the literature said if the target here will be an esophoric or esotropic within 8 prism diopter, the rate of consecutive esotropia will be very high. So here the preferred result, it should be like ortho or residual exo within 8 prism diopter.
Okay. But still, there is still a risk of recurrence because of the poor of vision. If you make it ortho or residual
Yes,
exo, there is still
yes.
risk
I
of
have I
recurrence.
have one patient. I have one patient with sensory exotropia, 35 prism diopter. I operate on the non-fixating eye, 7 millimeter lateral rectus recession, and 4.5 millimeter resection of the medial rectus. After the surgery, the patient came to me ortho, and after 1 month, the patient came to be with consecutive esotropia 35 prism diopter.
How old
I
is he? The age?
I think like 25 years old.
Okay.
I wait at least for 2 months, the same. I wait another 1 month, the same. The decision was for the operation for advancement of the medial rectus and lateral rectus. And after that, the patient came to me ortho, and after 1 to 2 weeks, came to be with 25 prism diopter exotropia. So here you cannot predict because you don't have the main power, which is the vision here. The vision is the main power to control two eyes. It should like that the vision is a power that makes the eye move from where to where alongside each other.
So the problem here, because it's sensory, so the problem here, there is no a good vision, so there is poor fusion. So the eye, it will not work together with make a normal fusion spontaneously. So there is abnormal fusion. This is why the
Yes,
squint, it come back again and again.
yes. I have one note. When the normal population awake from the sleep, the eyes will be in the divergence position because of very poor vision. But when the patient, sorry, when the normal population takes a few of seconds and regain the normal vision, the eyes moves together.
Okay. Thank you, Dr. Muhammad, so much. Yes, Sarah, continue the surgery plan.
I think the hypertrophy is not obvious because it is at the distance. In picture took at near. Here as
Okay.
I think.
The hypertropia is not very clear here.
Yes.
Okay. Yes, Sarah, please.
Surgery with no surprise on force duction test. I proceeded with the plan described above using the short tag nose approach to allow for delayed adjustment. Procedure summary: left medial resection 4 mm, resected 5.5 mm with a 1.5 mm hang back, adjustable with inferior displacement, half tendon width. Left lateral rectus recession 7 mm, adjustable with inferior displacement, half tendon width. Post-operative assessment: 2 hours after surgery, the patient had the following measurement by Krimsky. Distance esotropia, 12 prism diopter, at near esotropia, 20 prism diopter. These measurements were quite variable. Since the patient had poor vision in left eye, I didn't want to adjust to make him orthotropic in primary gaze, even at near, because that would have likely resulted in return of his exotropic over time. Given the variable nature of measurements, no further adjustment was performed. Yani he left him isotropic, even though the angle of the 12 prism diopter at near was greater than I had intended. I asked the patient to return in 24 hours to reassess the alignment for possible readjustment. Interim post-op assessment, post-op day 1, 24 hours after surgery, the patient had the following measurement by Krimsky: distance esotropia 12 prism diopter, the same, while near esotropia 12 prism diopter. Considering the poor VA in left eye, I felt that it would be acceptable to leave him at esotropic of 12 prism diopter, even at near, anticipating some post-operative drift and taking advantage of lack of diplopia. Although the patient and his family had some concern about the overcorrection, I reassured that this was the desired post-op day 1 alignment and no adjustment was performed. In follow-up, to visit 2 months after surgery, the patient was very happy with the result of surgery. He denied any diplopia. On examination, external examination, no tilt or turn, sensory motor evaluation, motility duction version full, not shown with only primary position alignment in photograph, deviation, distance ortho, while at near esotropia, I think intermittent 6 prism diopter with a small left hypotropia, not affecting appearance.
Okay.
But
Before we,
hypotropia obvious here in the picture.
yes. So, Dr. Muhammad, about the assessment of post-op, he have esotropia 12 for distance, esotropia 20 for near, and he keep him here isotropic. He didn't even
I
make,
don't really, I
yeah,
don't agree with the author here.
yeah,
You know, we don't have a good prediction of the result. But I think you can find in the literature the target here, it should be like an ortho or residual exo, because the risk of consecutive esotropia, it will be very high if you have a patient with if you have a patient with a consecutive esotropia after the surgery.
Okay, but look here, follow up. The patient was very happy with the result of surgery after 2 months,
This
and
is
there is
this
no
is this is
diplopia.
a very short. This is a very short duration.
Yeah,
Uh, just think in my story. I told you I have the patient with a very good result at the first follow up and at 1 month, and after 2 months the patient became
consecutive.
consecutive esotropia. Yes, this is the very short duration.
Okay, okay. So we should wait. Okay, let us see what happened or what is the lesson learned. Dr. Aima, can you read?
Assalamu alaikum. Yes, I can read. Can you tell me where to read from?
Yes, review lessons learned. The last
All
paragraph.
right. Closed head trauma can cause damage to the sixth cranial nerve, and it manifests as an concomitant horizontal diplopia and esotropia in primary gaze that is worse at distance than at near. The esotropia is often larger when the patient fixates with the paretic eye due to a secondary deviation. In this patient, there was no diplopia or secondary deviation since he had very poor vision in the affected eye. The sixth nerve ultimately recovered, but the patient developed a sensory exotropia due to the loss of vision from the traumatic optic neuropathy on the left. When the when the patient has poor vision in one eye, the alignment must be assessed using the Krimsky's test. The test is most easily performed at near. The patient is asked to fixate on a target, and when the prism bar is placed over one eye, with increasing prism power used until both corneal light reflexes are centered. My preference is to place the prism over the eye with better vision in order to have an unencumbered view of the corneal light reflex in the deviating eye. However, if fixation with the preferred eye induces a secondary deviation due to restriction or paresis of a muscle on that side, I will place the prism over the eye that is going to have surgery to closely stimulate the post-operative alignment. Distance Krimsky measurements are more of a challenge as the centration of the light reflexes must be assessed while the patient fixates on a distant light, such as TV screen with a white image. But with practice, this can be done. In most cases of reconstructive strabismus surgery, it is the near angle that matters most. This case illustrates the advantage of being able to defer post-operative adjustment and the need to anticipate post-operative drift towards exotropia, especially in patients with poor vision in one eye. Sometimes you have to trust your numbers, and here I, I had already operated for 25 prism diopters, even though there were some preoperative measurements that were up to 35 prism diopters. Had I performed a suture adjustment to reduce the esotropia in the immediate postoperative period on the day of surgery, or even on postoperative day 1, his exotropia would have likely recurred.
Yes, thank you, Dr. Ayman. Dr. Muhammad, here he said he preferred to put the prism over the eye with better vision in order to have an encumbered view of the corneal right reflex. So
This is the modified case.
yeah, so he prefer modified Krimsky. Do you think they are end, I think, with the same result? But why he prefer modified Krimsky more than the Krimsky? Krimsky, we put the prism on the deviated eye and we put the light. And just I want to say here some notes about the Krimsky. Krimsky, if you hear the eye,
Because
okay,
because
just I
okay.
want to say one point. So when you put the prism, you should put the light at a level about 30 to 50 centimeter from the patient, and you should make your eye, the eye of the examiner, aligned with the eye of the patient, and the light in the center, and should be on a distance in the center of 30 to 50 centimeter. This is, I think, very important point to do Krimsky or modified Krimsky, even when you do Hirschberg, you should be aligned at the same level, your eyes with the patient. You should be at the distance of 30 to 50 centimeter. The light should be at the center, and you put the prism and you look at the light until the deviated eye, the light become at the center of the pupil, you will reach the angle. If you put it at the deviated eye, we call it a Krimsky. If you put it at the fixed eye, we call it modified Krimsky. Yes, Dr. Muhammad, please. What is your comment?
We prefer a modified krimsky because when you are doing the modified krimsky, you are holding the prism bar in front of the fixating eye, the sound eye, and you observe the light in the deviating eye. But if
Yes.
you are but if you are doing the krimsky, you are holding the prism bar in front of the deviating eye, and you should observe the light behind the prism bar in this non-deviating eye, which is very difficult to us. So
Okay.
we prefer the modified Krimsky because we are holding the prism bar in front of the one eye and observe the light reflects on the another eye.
Okay. Thank you. Do you want to add any comment about his result, about the last three paragraph? He said the lesson, or you think you are not agree with this
No,
plan?
no, but the lesson here it's a non-predictable. The sensor exotropia we prefer to operate again on the non-fixating eye, not 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 because of the very good result. No, no, it's because we cannot guarantee the complication of the surgery, so we avoid to operate on the sound eye. In the literature again said that if you are operate on the sound eye in sensory exotropia, the result will be very good in comparison to operation just on the non-deviating eye, in non-fixating eye. But because of the complication again, we avoid to operate anything on the sound eye.
And always the rule when you read any book, always they said always work in, if you have amblyopia or you have sensory exo or you have a problem vision in one eye, always you work at one eye surgery and you target this eye with amblyogenic eye, or like this he has light perception in left eye and he targeted his left eye. Always we try to be far of the normal eye. We didn't try to affect their muscles or have complication, and in this eye he has good vision in it and everything normal, so always we work at the weak eye, and this is like a general rule everywhere. So I agree still with this, but you said in the literature it's not if you work at the sound eye you will have also good result. Yes, this is what I get your point, Dr. Muhammad, what I
Yes,
understand from you.
yes.
Okay. Okay, Dr. Ayman, can you please read the review questions?
Yes, sir. Review questions. What are the manifestations of a sixth nerve palsy? Patients with the sixth nerve palsy will have horizontal diplopia with an esotropia with an concomitant esotropia greater in the field of action of the affected lateral rectus muscle and greater at distance than at near. Why did this patient not have an esotropia if he had sixth nerve palsy? The sixth nerve palsy occurred early in the course of his injury. Over time, the nerve recovered, but he also had profound vision loss. As a result, he ended up with a sensory exotropia. What should the target alignment be for patients with sensory exotropia? The goal should be significant esotropia, while the target for most patients with exotropia should be an overcorrection at distance. For patients with sensory exotropia or suppression, the target should be overcorrection at near as well.
Okay, thank you so much, Dr. Ayman. Yes, Dr. Muhammad, the last question, I didn't get the point. He said your target should be
Yes,
overcorrection at
the
distance.
author thought it about the overcorrection. It should decrease the rate of recurrence. I don't think. I don't think.
Yeah, but he said exotropia should be overcorrected at distance, and for patient with sensory exotropia suppression, the target should be overcorrection at near as well. So he
Because
prefer
you
overcorrection. Yeah.
yes, you have here a difference in the angle between the far and near. In general, when you are treating the exotropia, the target it should be on the far angle. And sometimes, if you have a significant difference between the far and the near, you can get the midpoint between the far and near. But again, the target mostly, if you have insignificant value between the far and near, you should target the far angle. But here he highlight the near angle also in sensor exotropia and should be in your consideration when you are treating a sensor exotropia.
Okay. Thank you so much, Dr. Muhammad, for your comments. Anyone have any questions before I stop the record?
دكتور محمد what about the final يعني time اللي احنا we decide that this is the final result.
No time.
No
We
time.
have a consecutive either esotropia or exotropia after years.
Mm.
And I saw the patient with a consecutive exotropia after esotropic correction, essential esotropia after 20 years.
Wow.
Actually, Dr. Sarah, I remember a story. Uh, one of the adult male, he came to my consultant. He told him, I want to engage and I want to get married, but I have this sensory exotropia. He told him, listen, I will do surgery, recess resect in this eye. You will be straight. You will get your wife. And after 3 to 5 years, you will come
You will
back
be
again,
divorced.
exotropia.
Divorced.
No, you will have exotropia again. So he accepted. And he became straight and he get married and he is happy. But he told him after 3 to 5 years, it will be recurrence again from his experience. So there is always risk of recurrence. There is no vision, so there is no fusion. There is a problem in the sensory like department that are responsible for the fusion in the brain that will give the order to the muscle to see the object together. So this problem, it will make always a problem in the alignment. So this will lead to the recurrence. So in these cases, always the story, it's unpredictable. Uh, Anyone have any other question for Dr. Muhammad?
What about the angle? Why he decide to work on 25, not in 30 or not in 35 prism diopter here in this case?
He said in the case, my measurement is a 25, and I send the case to orthoptic assessment.
Mm.
Optometrist,
So he depends on his measurement.
yeah,
Yes.
he depend on the measurement of the surgeon, not
Okay.
on the other orthoptic assessment guy.
Yes.
Yes, this is the point. Any other questions?
You know, Dr.
Yes.
Sarah, in sensory exotropia, most of these patients will have a variable angles. Sometimes 25, sometimes 30, sometimes 35 on the same session, on multiple session. Because of that, we get an average of these measurements.
Yes.
Thank you.
It's not exactly like very, very, very accurate, you mean, Dr. Muhammad. There is variation. This is what you say?
Yes, yes.
Okay. I will show the last case today. Just it's an interesting case. And okay. Dr. Ayman, can you tell me about the motility of this patient? When she looked to the right, what you see, and when she looked to the left, what you see? Yes, Ayman?
So can you play when she looks at right, there's limited movement of her left eye.
Yeah. And what about palpebral fissure of the right eye here? You
Yeah.
see there is narrowing in the palpebral fissure.
It's
Also,
narrow.
yeah, there is mild limitation also in abduction here and mild limitation in adduction here. Okay, let us continue the video. Now she looked to the other side. What you see, Ayman? If you see in the other side also there is limitation. Limitation in the abduction. It's not fully. Look here. She tried to reach fully, but it's still not reach fully. And also in the other sides, left and right. Limitation in adduction and abduction in both eyes. Dr. Muhammad, this is your case. Can you please make the comment or make explanation about this, please?
Yes. Again, this is patient on the primary position. Looks like ortho in the primary position, but on the right gaze, we have a limited in abduction and abduction. Abduction in the right eye and abduction in the left eye, and narrowing of palpebral fissure in the right eye. The same thing in the left eye. When the left eye looking toward the left gaze, we have a left limitation in abduction and right limitation in adduction, and also limitation and narrowing of palpebral fissure in the left eye, especially when looking toward left gaze. So this is a very unique case of the Duane, which is called inverse Duane syndrome, bilateral inverse Duane syndrome.
Thank you so much, Dr. Muhammad. So in Duane syndrome, we have type 1, type 2, type 3. We will explain it later on in the other session. But in type 3, always we have limitation in adduction and abduction. But always the narrowing of palpebral fissure in adduction, but here the narrowing of palpebral fissure in both eye in abduction, not in adduction. This is a rare case of inverse Duane syndrome. Thank you so much, Dr. Muhammad. Thank you so much, Dr. Sarah.
I have one
Yes.
comment in this patient again.
Yeah.
In routine cases of Duane, the narrowing of palpebral fissure on adduction, it's because of the malinnervation or misinnervation in the left and in the lateral and medial rectus. But here, the pathogenesis mostly is due to a restrictive pattern or contracture of the medial rectus. Contracture of the medial rectus. This is the pathogenesis here. It's not a innervation. It's about the restrictive cause and contracture in the medial rectus.
Okay. Thank you so much. Very nice information. Anyone have any question before we finish the session? Okay, I think we discuss all of the things for today. Thank you. Thank you so much, Dr. Muhammad, Dr. Ayman, Dr. Sarah, everyone join us. Thank you so much. Inshallah, we will continue next week.